All right. Hello, everyone, and welcome. Thank you so much for joining us for this evening's event. My name is Bridget Ireland, and on behalf of Jefferson's Office of Alumni Relations, I want to thank you for joining us this evening. Tonight, we will all be learning about heart health from Dr. Eugene Storozynsky. Following his presentation, we'll be taking your questions. So throughout the presentation, please feel free to submit them through the Q&A button at the bottom of your screen, and we'll be sure to get to as many questions as we can before the end of the event. Now, to get us started, I'd like to introduce Dr. Storozynsky. Dr. Storozynsky has his MD PhD degree from the University of Rochester and a BS in biochemistry from the University of Rochester. As the inaugural Enterprise Chief of Cardio-Oncology at Jefferson Health, his goal is to work closely with Jefferson's 4 regional cancer center hubs and cardiologists interested in the cardiovascular management of the oncology patient, and to provide seamless cardiovascular care to the cancer patient and the cancer survivor. Dr. Storozynsky's research interests include identifying disparities in cardiovascular complications and finding novel ways to predict patients at increased risk of cardiovascular complications from oncologic treatment through use of multimodality imaging, biomarkers, and arrhythmia potential. Dr. Storozynsky, thank you so much for being with us this evening. The floor is yours.
Thank you, Bridget, for such a great invitation, for the very nice presentation and such. So I'm going to try to go ahead and see if I can share my screen. Well, again, thank you very much. It's really, truly a pleasure and an honor to present today to the Jefferson Medical School alumni. And really, this is a topic that I think is very important and very timely, especially given that today, February 1st, kicks off the first day of Women's Heart Health Month. I have no disclosures to present. And really, what I'd like to do in the next 40 minutes or so is just talk a little bit about the importance of recognizing cardiovascular toxicity. Why do we talk about it? And then briefly mention some of the offending agents that may play a role in causing or promoting underlying cardiovascular complications. And when I mention these offending agents, we'll just briefly go over the mechanisms, how to monitor this, as well as how to manage these patients in order for these patients to have truly the goal of which is to truly get them treated for their underlying malignancy and put them into remission while preventing any subsequent cardiovascular complications. So why discuss cardiac disease and cancer? Well, as you probably can figure out, these are really the 2 most common disease conditions in the world. And as you can see here, based on data from the Centers of Disease Control, this data is from the mid 2000s, but it still holds true today. You see that heart disease far outpaces malignant neoplasms, and either of these conditions individually far outpaces all of the next common causes of mortality in the United States and in the developed world. Not surprisingly, as we age, the incidence of cancer and heart disease increases and may occur concurrently, as was shown here by Driver et al., looking at the physician health study patient population and seeing that the risk of major cardiovascular disease, as shown here in the red dotted lines, dramatically increases in the 7th and 8th decade of life, as does the risk of cancer. In addition, as we see here, through a lot of innovation and discoveries and implementation of both novel oncologic agents, as well as the introduction of statin therapy, cardiovascular risk factor modification, we see that compared to the 1970s, there's been a significant overall improvement in mortality, certainly for heart disease in patients that are less than age 65, where you could see that in 1975, about a quarter of all deaths were related to heart disease. And now that's decreased down to about 17%. However, in this younger patient population, the incidence of neoplasm-related death and complications is still about the same. It's still about 22% or so from the 1970s and to the mid-2000s. And as you can see in the second panel, in those patients that are over the age of 65, that back in 1975, about 1/2 of those patients died of heart disease, but now it's been improved down to about a quarter of patients that die of heart disease. Whereas neoplasms were about 18% of all deaths in this population, whereas in 2018, that has actually increased to about 1/5 of all deaths being secondary to neoplasms. Now, it's unclear as to why that is, whether it's because of increased cancers related to tobacco use, for example. Is it due to the fact that these patients may, although they may not die from their heart disease, they may not be treated as aggressively for their malignancies due to concomitant cardiovascular disease? So that is still research that is ongoing. What we do know, however, is that there are significant racial and sex disparities that occur. And this has been shown by the SEER database that shows that although the incidence of cancer may be similar between African American men and Caucasian men, we see that the mortality is lower in Caucasian men compared to African American men. And the same is also true in African American females, that the percent survival is greater in Caucasian females with a higher mortality in African American females. And that is something that needs to be further understood. Is it due to economic reasons? Is it because patients are unable to seek healthcare in a timely fashion? Is it because of education that prevents people from continuing with their therapies and following their physician's recommendations, et cetera? What are some of the facts about cancer? Well, we know that about 40% of men and women will be diagnosed with cancer at some point during their lifetimes. And if we take a look at childhood and pediatric cancers, there are approximately 17,000 children and adolescents under the age of 19 that have been diagnosed with cancer. And roughly about 10% of these patients, unfortunately, succumb to their disease. And more importantly, as of January of 2019, there were estimated to be approximately 17 million cancer survivors in the United States. And as our therapies become better, that number of survivors is only projected to increase to greater than 22 million by 2030. Well, why is that of concern? Of course, we want patients that are diagnosed with cancer to be identified early, to be treated early, and to be cured if possible. But what we don't want is for those patients to, once they are cured, to be potentially forgotten about because of potential lifelong ramifications of their treatments that they had received. What are some of the trends in relative survival rates in children? As you can see here, that in the 1970s, only about 60% of children had survived. But since the mid 2000s, that number has increased to almost 85%. And certainly that number is very apparent in the identification and treatment of leukemia, but also brain and non-neurologic cancers are also have been shown to be responded to a lot of novel chemotherapeutic and oncologic treatments, resulting in an increase in survivorship. Well, why is that important for us? Well, this is a very elegant study that was done by Armstrong et al. Not too long ago, just within the last 2 years, in which basically the group asked one question. If you compare your sibling to yourself, meaning the person that's undergone cancer treatment, is there, because of the fact that you've received treatment in your lifetime for your cancer, do you have an increased risk compared to your sibling of cardiovascular risk factors, such as hypertension, diabetes, dyslipidemia? And what they found in this study, quite surprising, was that over time, the patient that is the cancer survivor, shown here in the blue line, has a significant increase in risk of hypertension, dyslipidemia, and diabetes compared to their sibling. In contrast, their sibling has a higher incidence of developing obesity. And despite developing obesity, that does not necessarily translate into the development of traditional cardiovascular risk factors. So this is yet some epidemiological data suggesting that simply being treated for a cancer at any time of your life puts you at a greater risk for future cardiovascular risk factors. So what are some of the oncologic treatments that have been associated with cardiovascular toxicities? And I really like this slide, and this is something that I've adapted from Dr. Javid Moussalehi and colleagues. But as you can see here, here is the iceberg that you see above the water, above the sea level. And as part of this iceberg, you see some of the traditional cancer treatments that have been recently identified and recognized as potentially contributing to cardiovascular toxicity, including mantle radiation, anthracyclines, anti-metabolite agents such as 5-fluorouracil that is really utilized very often for colon cancers. Anthracyclines are the bedrock for treatment of many cancers such as sarcomas, breast cancers, as you know. VEGF inhibitors, vascular endothelial growth factor inhibitors, that are treatments for cancers such as renal cell carcinoma, sarcomas. And then some of the tyrosine kinase inhibitors, including imatinib, dasatinib, and I'd be remiss if I don't mention HER2-targeted therapies that are oftentimes used nearly ubiquitously in patients with breast cancer that express HER2 receptor, and even more recently in some forms of gastrointestinal cancer that have been identified as expressing HER2 therapies. So a lot of these treatments have been associated with cardiovascular toxicity, including pericarditis, the development of coronary artery disease, valvular stenosis for those individuals that have received mantle radiation. Anthracyclines can lead to cardiomyopathy. Antimetabolites, because of their potential for developing vasospasm, can lead to coronary artery ischemia. VEGF inhibitors that have been identified as causing hypertension, which can lead to heart failure, and due to the rarefication of blood vessels, can lead to the promotion of thrombosis. And the tyrosine kinase inhibitors that have been associated with pulmonary arteriolar hypertension, et cetera. But are these all of the agents that are really responsible potentially for cardiovascular toxicity? Well, as you can see here, as new cancer therapies are coming down the pipeline, we are learning that although these therapies are very effective, many of them in treating cancer, and oftentimes may be used as maintenance therapy, they have definitely been associated with cardiovascular toxicity. And for the cancer immunotherapies, we find instances of myocarditis, instances of arrhythmias. The immunomodulating agents, such as tamoxifen and others, thalidomide, that can promote thrombosis, proteasome inhibitors such as bortezomib, carfilzomib, which is the mainstay for treatment of multiple myeloma and other hematologic malignancies, have been associated with hypertension. The Bruton tyrosine kinase inhibitors, such as ibrutinib, that are the mainstay for treatment of CLL, have been associated with an upwards of 40% incidence of arrhythmias such as atrial fibrillation, and the MEK and RAF tyrosine kinase inhibitors that have been associated with cardiomyopathy and others. And here at the bottom of this iceberg, the largest part of the iceberg, you see cancer survivorship. And really, cancer survivorship is something that we need to all pay much more attention to and much closer attention to be able to identify patients that are at risk for potentially developing these complications. How do we define chemotherapy-induced cardiomyopathy? Well, there are really three ways, not surprisingly. One is by symptom, one is by signs, and lastly, it's by some form of imaging. The symptoms can be non-specific, such as dyspnea, orthopnea, lower extremity swelling. For those that are oncologists on the webinar, you know that these are very non-specific symptoms, and many of our patients develop dyspnea and peripheral edema because of the steroid pretreatments, for example. They also may very well be tachycardic. Sinus tachycardia is one of the most common initial signs, potentially, of cardiovascular toxicity. But oftentimes, tachycardia is associated with anemia that these patients may develop because of bone marrow suppression. Uh, um, and so we then have to resort to imaging modalities that allow us to visualize changes in heart function from a baseline, or the new development of valvular abnormalities, or the development of things such as pulmonary hypertension, to say that these patients, although they may be responding to their specific oncologic agents, might be developing complications from them. What are some of the mechanisms of chemotherapy-induced cardiovascular toxicity? Well, I think the best characterized to date is the mechanism by which anthracyclines have been associated with causing cardiovascular toxicity. For most of you, as you probably remember, dating back to those good old medical school days, anthracyclines were originally isolated from bacteria, from the Streptomyces pusidus bacterium, and initially was used as an antibiotic, and subsequently was found to have very broad anti-tumor activity. And as a result of that, anthracyclines have really been the mainstay or the pillar for most chemotherapy regimens. And this slide kind of shows some of the proposed mechanisms by which anthracyclines may cause cardiotoxicity. They can cause free radical production, resulting in superoxide radicals, causing direct myocardial damage. They can inhibit DNA, the topoisomerase molecules. That's extremely important in repairing damaged DNA. And with the damaged DNA, that can ultimately lead to cell death. And then, in addition, it can result in the downregulation of the calcium modulating protein called SERCA2, which is found within the cytoplasmic reticulum of the cardiomyocyte. And with the downregulation of SERCA2, you can have a buildup of intracellular calcium that can lead directly to apoptosis. And all of these mechanisms ultimately can lead to the pathognomonic pathologic finding by electron microscopy, if you were to do an endomyocardial biopsy of this myofibrillar disarray, in which the myofibers, rather than being in parallel with each other, are in complete disarray. And this, as I mentioned, is pathognomonic for anthracycline-induced cardiotoxicity. And what this slide shows by Mulroney et al. Is that it doesn't really matter the degree or the cumulative dose of anthracycline, but that the higher the dose, especially in children, the faster the potential incidence of cardiac disorders. So as you can see here in the green dotted line, that for those patients that have received more than 250 milligrams per meter squared cumulative dose, you can see that as far as early as 10 years, 15 years, these patients can have a 2.5 increased risk of cardiovascular toxicity, compared to those patients that have received less than 250 milligrams per meter squared. And you can see that that risk, it's not zero, and it still can take up to 20 to 30 years, but those patients are definitely at risk for cardiovascular toxicity. And this is in comparison to patients that have never been exposed to an anthracycline. And certainly in the adult population, we know that the magic number seems to be approximately anywhere between 300 and 450 milligrams per meter squared, in which you see this inflection point of patients that all of a sudden will develop cardiotoxicity. And the higher the dose, the more likely the development of congestive heart failure. So what are some of the risk factors Well, we know it's the chemotherapy dose, as I mentioned, and also the schedule, the mode of administration. So bolus versus infusion. Bolus seems to be worse. Women appear to be more affected than men, and we don't understand quite why yet. Certainly, for those patients that have underlying risk factors, age, hypertension, hyperlipidemia, ongoing smoking, diabetes, these are all risk factors for developing anthracycline cardiotoxicity. Not surprisingly, if a patient has had previous cardiac disease, if they've had previous mediastinal radiation because of the valvular pathology, the potential for accelerated coronary artery disease. And then for those individuals that are being given Herceptin, if they have concurrent or sequential Herceptin use, that certainly increases or potentiates the possibility of anthracycline-induced cardiotoxicity. And most importantly, this increased length of time since anthracycline completion. So I think one of the biggest mistakes that can be made for the cardiologist or the primary care physician or the oncologist really is for the survivorship patient is to not follow these patients over time from a cardiovascular perspective in order to monitor them for the potential development of pathology that may be asymptomatic, but may be extremely important to identify early. Turning to the mechanisms by which trastuzumab, HER2, and pertuzumab work, or Enhertu, you can see here that the trastuzumab binds to the subdomain 4 of the HER2 receptor, whereas the pertuzumab binds to the subdomain 2 of the HER2 molecule. And this is oftentimes a strategy to combine both of these agents for the cancer patient that expresses high levels of HER2 for a more comprehensive HER blockade and potentiating remission and treatment of HER2 positive breast cancers. But as we know, about a third of women may develop cardiomyopathy secondary to Herceptin exposure. And the two possible mechanisms by which this may happen include a direct mechanism and an indirect mechanism. The direct mechanism really is the binding of the Herceptin agent to the ERB receptor. And the ERB receptor is extremely important in the cardiomyocytes because the ERB receptor promotes growth, promotes repair, and also promotes contractile dysfunction. And when you have inhibition of the ERB receptor because of ATP depletion, that results in contractile dysfunction, and that can lead to apoptosis. The indirect mechanism may be a possible immune-mediated destruction in which T lymphocytes, possibly because of molecular mimicry, recognize the ERB and Herceptin molecule as being foreign, and consequently it initiates a cascade reaction resulting in immune-mediated destruction through antibody formation and then also through cellular toxicity. What are some of the standard risk factors for developing the trastuzumab toxicity? Not surprisingly, they're similar to those that can occur in developing structural heart disease. So things like hypertension, things like hyperlipidemia, previous doxorubicin exposure, as I mentioned in the previous slide, previous chest wall irradiation. And here we find obesity appears to be a risk factor. And we don't exactly understand why that is. If there are some types of hormones that are produced in those patients with obesity that puts them at greater risk, or if it's because of the potential predisposition for diabetes, et cetera. As we know, the development of trastuzumab toxicity appears to be largely reversible, but it's not always 100%. And really, the best course is try to prevent it by treating underlying risk factors that someone may have for cardiovascular disease prior to initiating trastuzumab. And this brings me to the development of basically two models for cardiovascular cardiotoxicity. And the two models were the model as put forth by doxorubicin, and the second model is put forth by trastuzumab. And that led Ewer and Ewer brothers to postulate that there's a type 1 of chemotherapy-related cardiotoxicity and a type 2. And the type 1 model was evident through cellular death, typical anthracycline biopsy, as I showed you, that shows the myofibrillar disarray, and that it appears to be dose-related and may result in permanent damage, whereas the type 2, as modeled by trastuzumab, results in cellular dysfunction, but not death. There are no typical anthracycline-like biopsy changes. This seems to be independent of the dose, so it can happen at any time. And as I mentioned, it's generally reversible. And I would actually say that these two models are oversimplifications. And I think what's most important is early identification, as we'll discuss in the next couple of slides, because I think that even those patients that have only been treated with anthracyclines that have been shown to have cardiovascular toxicity can have recovery. So how do we survey for patients that may be at increased risk of developing cardiotoxicity? There are two main ways: through imaging and biomarkers. And if we talk about imaging, what are the most common modalities? These include echocardiography, nuclear cardiography, and MRI, magnetic resonance imaging. And so let's just talk about echocardiography. Here's a nice slide of patients that are undergoing treatment that receive echo contrast, and that allows the echocardiographer and the oncologist to be able to really identify well if there are any wall motion abnormalities. As you can see here, there aren't any wall motion abnormalities in the images on the right-hand side, which are the echo contrasted images. And we can also very easily quantify the volume of the ventricle in diastole when it's relaxing and in systole when it extracts the blood out, so that we can calculate a very accurate ejection fraction. And that's important because one of the first potential signs of cardiotoxicity may be left ventricular enlargement that we may only be able to identify through volumetric analysis. In addition to traditional echocardiography, there is a relatively novel technique called strain imaging that utilizes echocardiography for being able to measure in a longitudinal, radial or circumferential, and rotational means how individual myofibrils are contracting. And as you can see in this anatomic picture of the left ventricle, you see that the left ventricle is a very muscular layer that has fibers that are running circumferentially as well as longitudinally. And so in the next couple of slides, you'll see an echo that's being performed in real time, in which we're measuring the strain, which is depicted by the red lines. And the darker the red lines, as you can see in this image that is in motion, the more robust the squeeze is and the more robust the systolic function is. And so what I like to submit to the crowd here is that strain is a measurement of not ejection fraction, but of systolic function. And it is a more sensitive measurement of the health of the left ventricle. And so we can then calculate the strain in our different views of the left ventricle and compose a polar map, as you can see in the bottom right-hand corner. And this polar map will allow us to then determine by different segments where the abnormalities may lie. And as you can see here, there are no abnormalities. This is a patient of mine that was treated for Hodgkin's lymphoma when she was younger, and she came to me with complaints of tachycardia. When you look at this image without contrast, you think that the heart function is severely reduced. As you can see with echo contrast, the ejection fraction appears to be low normal. But then when we do the strain analysis, we find that only the apical segments are very dark red, and all of the other segments are either salmon colored or pink, meaning that their ability, their motion has dramatically decreased, presumably due to the previous exposure to the anthracycline. And what I like to let everybody know is that, the way that I look at strain is that it's the canary in the coal mine. The strain will become abnormal much sooner than there's a drop in the ejection fraction. And is this something important? Is this something that can be clinically useful to you? Well, in fact, it can be. And this is a study that was done in 2011 and looked in which patients were being treated for breast cancer. They were treated with anthracyclines and trastuzumab. And what they basically did was they followed their ejection fraction that was calculated volumetrically, and they followed the strain. And what they found was that in those patients that had no cardiotoxicity, there was no significant change in the strain value over time. You can see it was at baseline -20, and at completion, it's -19. But in those patients that had a decrease in their strain value, going from a baseline of -21 down to -16, that resulted over time in a concurrent reduction in the ejection fraction. So longitudinal strain at 3 months was able to predict toxicity at 6 months in this paper. And similarly, in patients that were being treated with anthracyclines, another paper showing that in those patients that had a reduction in their global longitudinal strain, they developed significant cardiovascular toxicity on the order of about 35% compared to those patients that had no change in their GLS scores. And here's an example of a patient of mine with breast cancer that had been placed on capecitabine. And for those of you that may not be familiar, it's a precursor or prodrug to 5-FU. It's a pill. And the patient, who was only in her 20s, an avid runner, and unfortunately was diagnosed with metastatic breast cancer, came to me when she was on the capecitabine and would tell me that at the tail end of her runs, she would develop these palpitations and she would feel that her heart's really running fast. And I wasn't sure if these were atrial in etiology or ventricular in etiology. So I decided to put her on a treadmill. Here's the resting echo strain prior to her going on the treadmill, and this is her EKG. And then you can see that as she completed her exercise at a very high level, she all of a sudden developed ventricular tachycardia. And you can see that there is a regionality to the strain, suggesting that she likely had vasospasm caused by the capecitabine. Let's just talk briefly about the value and utility of cardiac MRI. And the reason that we utilize MRI in these patients is really to try to identify patients that may have scar. And the way that we detect scar with MRI is by injecting patients with gadolinium. Gadolinium does not penetrate normal intact cellular membranes. But if you have a cell that has died, either because of myocardial infarction, so decreased blood flow, or potentially because of chemotherapy, you have no longer intact cells. The cell membrane is now ruptured, allowing for gadolinium to bind within the cell. And it can also bind into the collagen matrix. And it allows us to determine, based on the pattern of the scar, whether or not evidence of scar is due to coronary artery disease or due to a non-ischemic etiology. And why is it important to note the potential distribution of the scar? Well, this was very nicely illustrated by Chung et al. Back in 2009, in which they looked at patients that underwent CMR regardless of their history of coronary artery disease, and they had greater than 850 patients. The only question that they asked was there presence or absence of scar? And then they followed these patients over for greater than nearly 4.5 years. And they basically asked, okay, what was the severity of the score of the scar? And that resulted in a score. And also whether or not the scar was in a distribution due to the presence of coronary artery disease or no coronary artery disease. So as you can imagine, if the scar was in the endocardium, because that's the furthest point away from the epicardial blood flow, then that would denote coronary artery disease. But if there was scar that was present in the mid or epicardium, that was likely not vascular in etiology. And so what they found was that in those patients with coronary artery disease, the hazard ratio of scar predicting death and transplantation was only 1.33. So elevated, but not that significant. However, in those patients that had a high scar index that was independent or without coronary artery disease, those patients had a much, much greater, nearly 5-fold higher incidence of predicted death, cardiovascular mortality, or transplantation. So this is a very, very strong predictor, especially in patients with concern for cardiovascular toxicity secondary to chemotherapy, for being able to identify these patients. What about biomarkers? So very elegant papers, now almost greater than 20 years old, originating from Milan, Italy by Dr. Daniela Cardinale. She looked at 204 patients that were being treated with high doses of chemotherapy, anthracyclines, and she checked troponin I levels very early on after treatment, time 0 up to 72 hours after treatment. And what she found was that there were about a third of the patients had a positive troponin, but 2/3 of them did not. And as you can see here, those patients that had a positive troponin had a decrease in their ejection fraction compared to baseline, compared to those that had no troponin leak. Well, she took that one step further, and she now looked at 700 patients with poor prognosis malignancies, followed these patients for nearly 4 years, and basically asked the question, well, what if we check troponin at over a longer duration of time? So early was at the time of infusion, late was 30 days later. And what they found was that there was about 9% of patients had persistent elevated troponin levels. about 21% of patients had an initial elevated troponin level and then cleared at 30 days. And then about 70% of patients had no troponin leak. And when they follow these patients over time, they found that of those patients without troponin leak had a very low incidence of cardiovascular complications. Those patients with any troponin leak had a nearly 30% incidence of cardiovascular event rate. And then those patients that had a persistently elevated troponin had only a 20% cardiovascular survival. So troponin elevation may be a very important marker to follow in these patients to try to identify potentially those that might be at risk. Just a few words about, ongoing research looking at platelets and the fact that platelets are being found to be very important in promotion of cardiovascular disease and potentially, and also, promoting cancer, promotion of atherosclerosis, thrombosis, because of the release of inflammatory cytokines, vascular endothelial growth factors, et cetera. But this research is really in its infancy, and there is yet a lot that remains to be learned. So last couple of minutes, I'd like to spend just talking about the management. This is a very nice study that was done when I had just completed my fellowship, nearly 20 years ago in cardiology, in which patients that were being given high doses of anthracyclines were just pre-treated with carvedilol. And what they found is in those patients that had received carvedilol, there was no change in their ejection fraction over time. But in those patients that in the control group that were not being treated with carvedilol, they had a statistically significant, although still within a normal range, but a statistically significant reduction in their ejection fraction. Similarly, a study looking by Cardinale et al. Of using ACE inhibitors, what she did was those patients that had positive troponin, those patients received enalapril, and what she was able to show was that in those patients treated with ACE inhibitors, they had no evidence of LV dysfunction and no development of cardiac events, whereas the control group, nearly 50% of them had some cardiac event, whether it be sudden cardiac death, acute pulmonary edema, heart failure, acute coronary syndrome, or a life-threatening arrhythmia. What about dexrazoxazine and preventing anthracycline cardiotoxicity? Well, certainly there is definitely literature in the pediatric population that shows that those patients that have received greater than 300 milligrams per meter squared of anthracyclines, that doxorubicin may be protective and allow them to either continue to receive the anthracycline-based regimen if that's really their only regimen to promote remission. And so there's some ongoing debate as to trying to identify those patients that may benefit from this preventative strategy. One final topic that I wanted to talk about, and this gets back to the Uhr and Uhr proposed models for type 1 and type 2 chemotherapy-related cardiotoxicity, is a paper that, again, Daniela Cardinale published, in which she looked at 200 patients with anthracycline-induced cardiomyopathy as defined by a decrease in the ejection fraction to below 50%. And she basically looked at these patients, looked at their demographics, and treated them with an ACE inhibitor and beta blocker and followed them for over 3 years. And what she found was, regardless of the patient's age, regardless of the sex, regardless of the functional class, regardless of whether or not the patient received ACE inhibitor alone or ACE inhibitor plus beta blocker, the anthracycline dose, really the most predictive marker for successful reversal of the anthracycline-induced cardiotoxicity was time to initiation of heart failure medications. And so really the moral of the story is it's important to identify early, and it's important to intervene early in this patient population. And as you can see here in this plot, you see that the responders had a very relatively low incidence of cardiovascular complications, whereas the partial responders or the non-responders had a nearly 70 to 80% risk of cardiovascular toxicity over this 2-month period. In addition, I kind of alluded to this in one of the previous slides, but really it seems like the clinical benefit was most evident in patients that were asymptomatic. So in those patients that had no LV recovery, those were patients that had New York Heart Association functional class 3 to 4, and also in those patients that it took a very long time to identify them. And by the time we were trying to identify them, it was too late. What about statin therapy? Definitely some data. This is an epidemiological case control trial looking at statin therapy in breast cancer that came from the Cleveland Clinic back in 2012, so about 10 years ago, and certainly suggesting that statin therapy does have some protective benefits, as you see here in the red lines. In this red line, the patient was treated with statin therapy. And although the demographics were identical between these two groups of women, the statin therapy arm seemed to have a benefit, and it was independent of the lipid profile at the time. For those patients that, despite identifying them early, despite intervening on them with goal-directed medical therapy, they still have evidence of left ventricular dysfunction. They still have heart failure symptoms. Is there anything else that we can do for them? Well, this was a landmark trial that came out just about 2 years ago called the MADE-IT trial, the chemotherapy-induced cardiomyopathy trial, in which these patients were identified as having a chemotherapy-induced cardiomyopathy, no evidence of coronary artery disease, no evidence of significant valvular heart disease that was primary. And these patients were implanted either with a biventricular pacemaker or a biventricular AICD if they qualified for an AICD, and they were followed over time. And what you can see is that at the time of implantation, most of these patients had an ejection fraction mean of 27%. And after implantation, this ejection fraction had dramatically increased up to about 38%. And here's a picture of here's an example of a patient of mine, as I was one of the site, University of Rochester, where I was previously, was the coordinating site, and this is my patient. As you can see here, this is an echocardiogram showing that the left ventricle is markedly dilated, and she was very well controlled on medication, but yet despite that had still a very severely reduced ejection fraction. And this is 18 months after the implantation of the biventricular AICD, and you can see that the left ventricle is markedly reduced in size. The ejection fraction had actually normalized to 55%, determined volumetrically. And you can also see that there was a significant improvement in the overall systolic strain. And although the systolic strain had not yet normalized by the time of this 18-month echo, but it was nearly normal. So dramatic improvement of mechanical electrical resynchronization in this patient and in other examples of patients, despite being on really high doses of goal-directed heart failure medical therapy. I'd like to just kind of conclude tonight's talk to leave a little bit of time for questions to show that there are a lot of medications that can also affect the SERCA2 molecule and that may potentiate the effect of anthracycline therapy. And this includes things such as amitriptyline, cyclosporin, glucocorticoids, not surprisingly. And this may explain why medications such as beta blockers like carvedilol that can increase the activity and expression of SERCA2 is so beneficial in the patients with chemotherapy with anthracycline cardiotoxicity, but also ARB such as losartan, ACE inhibitors such as enalapril, as you can see here. And interestingly, some of the calcium channel blockers such as verapamil, felodipine, and others might actually downregulate the effect and function of SERCA2. So that might be a medication that may not be of benefit in this patient population. So I would like to just, conclude by basically saying that really it takes a multimodality and integrative approach to monitor patients that are on oncologic therapy and radiation therapy to try to reduce the incidence of left ventricular dysfunction. And things include aggressive risk factor modification, consider prospectively following biomarkers with chemotherapy dosing, the importance of cardiac imaging, especially using echo contrast, quantification, 3D measurements, if possible, and certain longitudinal strain. And doing this in a stepwise fashion as these patients are receiving higher and higher cumulative doses of their anthracyclines, or as well as their anti-Herceptin therapy. And that really there should be a relatively lower threshold for patients, if there is an abnormality on the echo, to confirm it with CMR, to be able to identify the degree of scar that's identified, and then to initiate goal-directed heart failure medical therapy sooner than later and modify all cardiovascular risk factors sooner than later in order to reduce the risk of cardiovascular toxicity. And with that, this is just one final slide that was just put forth recently by the European Society of Cardiology, that they put forth their in just this past summer, their cardio-oncology guidelines. And this is a very nice summary slide talking about long-term survival or surveillance in patients that had survived cancer. And this is in asymptomatic cancer survivors. Those patients that are at low risk should have an annual cardiovascular assessment. At moderate risk, probably should be referred to a cardio-oncologist and not just to a cardiologist, if that is possible. And then really for those people at moderate risk should have their cardiovascular risk re-stratified every 5 years. And for those patients that are at high or very high risk, they should have an increased frequency of monitoring of their cardiovascular function through echocardiography, potentially stress echocardiography if they've received mantle radiation to survey for accelerated coronary artery disease or valvular heart disease. And with that, I will conclude. Thank you very much, and happy to answer any questions if there are any.
So much great information there. I feel so much smarter just for listening to you. So thank you so much. It was so educational. I do want to invite everyone to chime in with questions. We do have a first question here, which I'll go ahead and read. But if you do have questions, please feel free to submit them through the Q&A button at the bottom of your screens. The first question here, and I apologize for anything I mispronounce, how long should patients who received anthracycline be followed, and how often should they get echocardiogram?
So if we kind of go back to the previous slide, that summary slide, I think, gives a very nice summary. These patients need to be followed lifelong. I think what happened, and this is something that we're really just learning as we have more and more survivors of cancer. What we're finding is that these patients are at increased risk over their lifetime of cardiovascular complications. And as a result of that, they really need to be followed long-term. And that means followed by annually, for example, by EKG, followed by their, I would even, I don't want to say that this is heretical, but we still don't have a lot of data for it. But I would actually say that these patients really should be placed on statin therapy if they have, even with normal lipid profiles. And really, one of the things that I often do in my patient population is that I may also check some immunologic markers, such as high sensitivity C-reactive protein or IL-6 levels, to determine whether or not these folks have a underlying predisposition to inflammation, even in the setting of normal lipids. Because as we know, based on the Jupiter trial, in which patients that were of Japanese ancestry that had, fairly normal lipid profiles, but elevated markers of inflammation, elevated quartiles of high sensitivity C-reactive protein, when those patients were placed on statin therapy compared to the control subjects, they were found to actually have, over time, a significant reduction in the development of carotid artery disease and intimal medial thickening, which was the surrogate marker for peripheral vascular disease and for cardiovascular heart health. So I would really argue that markers of inflammation is something that's very important to follow in these patients, and that these patients almost ubiquitously should be placed on statin therapy.
Have any other questions right now, but we'll give you all a minute or two to submit any more questions. I know we are over our time limit a little, but hopefully if you have questions, please feel free to submit them. We'll make sure everything gets answered. We'll give it just a minute here. Okay, it looks like we're not getting any other questions, but I'm going to say a few more things. If you think of a question while I'm talking, please feel free to throw it in there and we'll be sure to get it answered for you. So to wrap up tonight, I just want to thank Dr. Storozynsky again. Thank you so much for such a wonderful presentation and taking the time out of what I'm sure is your busy day to join us this evening. I would like to thank all of you for joining us. I know, especially nighttime after a long day, you could be many places, but we're so happy you chose to join us this evening. So thank you so much for that. Just a few reminders. Tomorrow you'll receive a link to this recording and it'll send you to our YouTube channel. Please feel free to share that amongst your Jefferson network. And speaking of networks, if you haven't already, we encourage you to join the Jefferson Alumni Network. It's our community for Jefferson, Textile, and Philadelphia University alumni. You can join that at alumninetwork.jefferson.edu. And over the next few months, we have a lot of great events coming up. So please feel free to check out what's happening at jefferson.edu/alumni events. And it looks like we've had no more question submissions. So if tonight we end this session and you all think of some great questions, please email alumni@jefferson.edu, and we'll be sure to get your questions to Dr. Storozynsky to make sure you get those answers. With all that being said, again, thank you all for joining us this evening, and we hope you have a great night. Thank you, Dr. Storozynsky.